Good afternoon, JC, and good morning to those of you on the West Coast. My name is Harris Allen, and I'm absolutely delighted to be doing this presentation today with my co-panelists, Bill Bunn and Mike Ordell. What we're going to be talking about today is a methodology that focuses on low back pain and the comparison of actual care delivered to guidelines for that care. We're talking, however, about something that can be used for not just exclusively to low back pain, but in fact across the wide range of high-cost diagnoses. And many employers have the capability of doing exactly what it is that we're talking about today. And what we're going to show is that the enormous power that can come from doing precisely this kind, taking these kinds of steps, because in fact, employers have the opportunity to provide input into the guideline calibration and recalibration process that is absolutely critical to the value and sustainability of healthcare. We're going to begin with Bill Bunn talking about giving an overview of the burden of low back pain, and it's going to be giving also an overview of the worksite that served as the place that provided the data for the study that I, in turn, will be describing in part 2 of the presentation. And what we've found in our results has enormous implications for the state of the art with respect to guidelines. And for that, we have Mike Ordell to discuss and explore for us. Mike has been involved with a number of different guideline development efforts over the years. So, Bill, could you begin, please?
I wanted to introduce the issues of low back pain. The first thing is we know that low back pain is a key issue in workers' compensation cases, disability cases, and in general medical care. We know that we've seen that about 80% of all workers' comp claims are musculoskeletal sprains, strains, and injuries. And low back pain injury accounts for about a third of workers' comp dollars. Back pain causes more than 313 million bed days, 187 million lost work days annually. On the productivity side, employers lose 5.9 hours of productivity per week per employee for musculoskeletal pain, and that really excludes a bit of presenteeism that we have to deal with. The cost of low back pain estimate is $39 to $78 billion in direct cost and $60 billion in indirect cost, and a lot of that may not actually capture the total cost of lost productivity. Okay, next slide. So the next slide basically shows the incremental and mean direct costs for spine conditions in 2011 dollars. The big issue here we can see is the cost is rising significantly from 1996 to 2011, and that seems to be continuing throughout, and we expect it to continue to increase over time. The per person component slide here is what you see here is ambulatory care is becoming a bigger piece of the puzzle. Inpatient care is becoming a slightly smaller piece of the puzzle, and prescription drug is clearly increasing more than the others percentage-wise. So this is the trend that we're seeing. We're going to see more outpatient care, more cost of prescription drugs. Low back pain visits per age group, and the point here is that even though we still have large numbers of folks over 75, we still have lots of working individuals in the 65 to 74 age group, and we also significant numbers in the 45 to 64 age group. So the bottom line is that you have back pain in every age group. It is increased as you get older, but we can see it really throughout a working career. So let's go to the overview at Navistar. Tell you a little bit about the company first. During this study, we were the largest maker of trucks and engines. Global population was around 17,000, with 11,000 in the U.S. An important issue for us was health care. Our retirees had health care, and the ratio was about 3 to 1. It was an older, mostly male population, large union representation, and again, the history of high health care costs per individual and in aggregate. Okay, what do we do at Navistar? One of the key things we did was to measure and manage with monthly analysis that actually went to our chairman of the board each month, as well as his direct reports. We manage both sides, both the supply side and the demand side, meaning we bargain with the providers that we have, pick the best providers, and try to minimize the cost per unit of health care. And really at the same time, we tried to reduce the incidence of adverse health problems. Our Vital Lives programs were a key part of that with our health promotion activities. One of the things we did in Vital Lives that was very important is we focused on not just primary, but also secondary and tertiary prevention. So things like we had increased exercise and those primary kind of things, but it went all the way through someone who might be in the hospital or regularly treated for cardiac failure, significant diabetes, etc. We had on-site medical facilities, which we think are a big piece of managing health care at our larger sites. We really had almost all the production sites had medical facilities. We had 16 disease management programs. Some were directly purchased, some were those that we put together. We used evidence-based health benefits management. Each quarter we looked at the diseases that we had, which were coded. We also looked at the use of pharmaceuticals, and that was a guideline for us for health benefits management. And we also incorporated things like health risk appraisals. So we weren't managing benefits simply by cost. We were trying to manage benefits by looking at trends, by looking at what would reduce disease in our population. This group, or Harris and I and others, published 12 studies on this population in the Journal of Occupational Environmental Medicine alone. Next slide. So this is our healthcare cost trend per employee. The top number with the bars, or the straight black line with the bars, shows national healthcare trend. As you can see, when we began the health and productivity focus in 2002, this is the beginning of the study, we were well above national guidelines for the previous 5 years. With the implementation of our health and productivity initiative and approach, in 2003 we began to bring the bar down. 2004 it increased, and then by 2009 we were significantly below the projected national numbers. Harris has gathered this was perhaps $300 million in savings. If you count other things, it may have been significantly more, like the reserves that we'd have to have. Looking at the workers' comp and disability costs, national trends versus at Navistar, the red bars are the national trend. The blue bars are Navistar's actual. So there's two significant points. One is that we were able to significantly reduce our costs throughout the course of 2001 through 2012. And in 2012, you can see the actual paid was only about a third or less of the projected amounts. Next slide, if you'll. So, in looking at controllable absenteeism, it follows very much disability and workers' comp. but our controllable absenteeism dropped from 5.0 to 1.8%. This was an annual savings of $2 million per 1,000 employees. So we're talking $22 million a year in 2010. This is very important for people to understand, is that running these programs not only gets people back to work, it also makes them more productive, but there's a significant savings cost that sometimes senior management doesn't realize. Back to musculoskeletal programs, we had aggressive management of ergonomics. We had ergonomics professionals, both management and union, at most of the large sites. We did a number of work hardening exercises. We had transitional exercise programs, which is particularly important in union situations when we transition folks from one job to another. We had the traditional programs for medication review. We looked at if prescriptions were filled on a regular basis or were used on a regular basis. And we had very good results in compliance during this period of time. There was an ongoing review of health and productivity, and we did that as we looked at cost. We also looked at other things like participation in various events, and we looked on a quarterly basis at specific diseases to see what the disease trends were in our population and to compare those with national trends. This helped us drive our health benefits design and our prevention efforts. So each year we reassessed where we were, and really each month, to look at health benefits design and prevention efforts. So when we came to the time for open enrollment, we had a different design perhaps than we had the year before, and we could redesign our prevention efforts. I would comment prevention efforts were tied to premiums for most of the population, and so successful prevention efforts like participation was rewarded with cost. At the same time, efforts, things like smoking, actually led to greater costs for the employees, about $500 a year with smoking, and about $500 you could gain from doing the appropriate health programs, and they were coded into different categories. Both these programs had high participation rates and seemed to be very important for the population. So let's look at the musculoskeletal disability management. Our initial study was in 2002 to 2004. It was at our largest plant. We had high musculoskeletal cost in disability and workers' compensation. We did the intervention at the site. We focused on physicians' reports, which hadn't been good. We implemented clinic practice guidelines, and we made guidelines mandatory for the physicians who saw our patients. One of the most important things was prompt clinical response. What we found in meeting with the physicians is they really didn't understand the jobs of the individual. They didn't understand exactly what happened. So it's very important to be in touch with the clinician and for them to know what happened and move rapidly to follow the guidelines. There were some keys for success in the program. Probably one of the biggest keys is this was a unionized plant, and we worked with the union, and they gave us excellent support at the end of the program. I'll have to say over the first part of the program we had some struggles, but by the end the union support was very important. Effective physician education. In this case, we used the orthopedic guidelines. We brought individuals in that were going to take care of our employees. We did educational programs for them at dinners. We made sure that each of them had the guidelines that would be put out. We actually had a partnership with a pharmaceutical company whose detail folks carried the guidelines around. So we set clear guidelines and clear expectations in the program. So what are the results? And one of the comments Harrison and I have gotten back many times is, are you sure you can get these returns when you start a program and you intervene and then you look at the cost in the end? And the answer is we did. Our injuries dropped from 125 to 16. Mean days lost dropped from 52.8 to 24.3. Indemnity cost from 14,192 to 2,565 per injury, and medical costs from 6322 to 1670 per injury. Comp cost per individual, we say $1,500 a year. That was a significant savings in this plant. That gives you an ROI of at least 40 to 1. So I think this is a good example to show you can get a tremendous ROI if you focus and you use guidelines in an effective fashion. So what was the impact of the study results? We knew we needed to comply and use the guidelines. We knew case management, hopefully day one case management of the cases, but certainly in the first 3 days, we wanted to get involved with the individual and return to work programs. The disease management programs tied in with the case management, and we had an opt-out disease management program where 97% of the folks stayed in the program. We refocused our site unit, health unit efforts. Musculoskeletal became a real focus for the physicians and nurses at our sites. We integrated it with our wellness programs. Again, we integrated it with our clinics. We brought most of PT on site, and also we had new ergonomics efforts, and PT is a big piece of what we did in this program. There are clear communications. We wanted the cost to go down, but we also wanted accidents to go down, and we wanted to prevent musculoskeletal injuries and illnesses. And we continue to measure and manage every month and try to make the changes that we could see from the cost and also from the number of injuries each month. Okay, so I'm going to turn it over to Harris now. After, as you recall, we had this first study in 2002 to 2004, and Harris is going to tell you about our most recent study in musculoskeletal disease. Harris?
Okay, thank you, Bill. Let me wait to get my thing up here.
Conference muted.
Okay. All right, what we did is we decided that we wanted to focus specifically on low back pain. And please hold for a second. Let me just make sure I get this right here. Okay, good. And excuse me. The reason is 84% of the general population has been shown, or it's been shown that it will have at least one occurrence of low back pain reported over their lifetime. It's the second most common symptom driving clinician visits in the United States, and it's the number one cause of workers' compensation. And what covers it, what surrounds all of the health care for low back pain is that there is still a lot of clinical uncertainty about what is the appropriate treatment. And despite the sharp increase in the use of imaging, surgery, medications, various forms of high-cost medical treatment, we really haven't seen any pervasive improvements in the functional status. No evidence yet reported for that, and no evidence yet of declining work disability. So what we wanted to do for this next study was we wanted to characterize the burden and the treatment patterns for low back pain, and we wanted to assess this care in relation to published guidelines. It turned out that in tracking the 21,000 plus employees that met our criteria for inclusion in the study from 2001 to 2009, literally 30% had at least one, if not more, than a back problem episode. We identified over 1,800 neurologic low back pain episodes, like, for example, low back pain where the primary diagnosis was sciatica. And we had over 8,500 non-neurologic episodes, like, for example, the diagnosis being lumbago. we identified 5 treatment approaches based on the first 6 weeks of claims. And then we totaled tracked the total costs associated with each episode up to 3 years if the episode lasted that long. Total costs being here all the direct costs stemming from care delivered to the individual patient, as well as total indirect costs. And here we included absenteeism, workers' comp, disability, short and long term. And we assessed the guidelines, the care delivered, relative to 11 different guidelines for imaging, surgery, medication use, and outpatient visits. And this was a claims-based analysis. Within that context, we were able to develop some reasonably good propensity-based methods to adjust for demographics and episode characteristics to make sure that our comparisons were reasonably comparable in terms of controlling for extraneous characteristics. These were the 5 different treatment approaches that we ended up identifying based on the first 6 weeks of claims. If the preponderance or the plurality of claims lines for the first 6 weeks was linked to a physical therapist, starting to the far right side there, then that would have been considered a physical therapist example of that particular approach, which we label physical therapy. Similarly for chiropractor. If within the first 6 weeks, more than one claims line was linked to a complex medical procedure, like, for example, surgery, then that was considered a complex major medical approach. If no one of these 3 first characteristics met our criteria for being the dominant form, they were considered the episode was considered an example of what we called our dabble approach. And if the first 6 weeks of claims were simply either going to the doctor for consultation or having some kind of imaging test done, then that episode was considered an example of a talk info approach. Along the bottom, you'll see the frequency distributions of the different categories of the approaches there. 11 different guidelines examined, 3 different imaging, 2 for surgery, 1 for outpatient treatment in terms of when the patient was to see the provider or chiropractor, and 5 different medication guidelines. So, for example, for one imaging had to do with the first MRI or CT scan for non-neurological episodes. The guideline that we called from the literature said that the first MRI or CT scan should be after the 12-week mark of the episode. So if that first MRI or CT scan occurred before the 12-week mark, then that episode was considered incongruent vis-a-vis that guideline. And you'll note here the element of time. This is a key linchpin to the methodology. We were able to look at our claims data to determine when a procedure occurred, and we used that as the basis for classifying congruent versus uncongruent or incongruent. Claims did not give us much of a basis for evaluating the quality of the care, but it could allow us to evaluate the timing aspect. And this is a key piece that holds for any kind of application along these lines with respect to other diagnoses that are possible. You can see here that the observed inconsistencies in terms of care actually delivered relative to the guidelines we looked at were substantial. Now, I should make a point here by saying that we're looking at care delivered between 2001 and 2009. relative to guidelines that were considered the state-of-the-art when we did the study itself retrospectively in 2013 and 2014. So we can't hold the standard here that necessarily that the physicians were being evaluated relative to published guidelines at the time they were delivering their care. But we can evaluate post hoc whether or not what they did was congruent with the state-of-the-art when we did the analysis that we did. Using that particular logic, we found that across all episodes, that the rates of inconsistent or incongruent care vis-a-vis the guidelines was substantial. Over 35% of all episodes had an X-ray before the 28-day mark. That was considered an incongruent aspect to that care for that episode. But it's even more striking when you look at all the episodes that had a given procedure or a medication. So, for example, all episodes that had a surgical intervention or major surgery, what we found was that of those episodes, literally 42% of the episodes occurred before the 365-day mark for non-neurological episodes. So very substantial rates of inconsistency with respect to, or incongruence with respect to care being delivered on the one hand and the guidelines that we evaluated them against. Total costs were quite substantial as well, as you might imagine. When care was inconsistent relative to when care was consistent vis-a-vis the guidelines, we're talking about in year one of the diagnoses, total costs being in many cases $5,000 greater for episodes where care was incongruent. And actually, in 10 out of the 11 guidelines that we looked at, the incongruent care was linked with significantly greater costs. There was, however, one instance where incongruent care was linked to actual savings. That had to do with when the first visit to a chiropractor or a physical therapist occurred. The guideline that we gleaned from looking our review of the literature, focusing primarily on the up-to-date online mechanism, that guideline said the first visit should wait 14 days. When the first visit to a physical therapist or a chiropractor occurred before the 14-day mark, there was significant savings. So incongruent care in this case led to savings. As you might imagine, of the 5 different treatment approaches, the more intense treatment approaches, major medical followed by physical therapy, were actually linked to the highest rates of guideline inconsistent use of imaging, surgery, and medication use. So for the 10 different guidelines that dealt with imaging, surgery, and medication use, complex major medical was most likely to report at least one incongruence with respect to one of the 10 different guidelines. And so the highest rates of prevalence in this regard. And the treatment costs associated, the total cost associated actually, followed the pattern, where complex major medical followed by physical therapy were the two most expensive, were the treatment patterns linked with the greatest total costs. Chiropractic, which was the least likely to use surgery and medications and imaging, and when they used those modalities, they were least likely to use them in an incongruent fashion chiropractic, in turn, turned out to be the least expensive, linked with the lowest total costs of the 5 different treatment approaches. But we're not simply talking about costs here. Here we're looking at a very intriguing finding that has to do with the short-term days per neurological episode. And what we found here is that our inconsistent care vis-a-vis the guidelines for things like MRIs, surgeries, opioid use, NSAID use, benzo use. Incongruent care was linked with short-term disability days that in excess of 5 to 10 to 20 to 25 days per episode. In contrast, with respect to physical therapy and chiropractic, when care was incongruent with the guideline, savings of up to 7 to 8 days or so occurred per episode. And these savings occurred across years 1, 2, and 3 of each episode. So conclusions to be gained from this. Number one, the high rates of guideline inconsistent use of imaging, surgery, and medications. When that was observed, what we found was that improved adherence to those guidelines will lead to greater savings. Conversely, high rates of guideline inconsistent first visits to physical therapists and chiropractors, when that is observed, what we find is that greater non-adherence will lead to greater savings. And that these distinctions had parallel impacts not only with respect to cost, but also with respect to disability and other drivers of lost productivity. So what we find here is this exercise where we're looking at actual care delivered relative to guidelines, and the assessment of the congruence between the two, or consistency, actually becomes or can become a new lever for management. Now, no one is here to say that total costs are more important than other factors that go into the guideline creation, calibration, recalibration process. But what we would maintain is that purchaser priorities are no less important than other stakeholder groups. And employers, for obvious reasons, have strong reasons to want to ensure that guidelines are exerting optimal impacts. And by virtue of their database and analytic assets, they are actually in a unique position to provide input into guidelines, to improve them, to advance the value and sustainability that results from guidelines. And, this is something, once again, that we found here for low back pain. There's no reason to think that employers should not be interested in going through a very similar exercise on their own, looking vis-a-vis their own employee populations, vis-a-vis other diagnoses. Bottom line, employers, we would suggest, belong at the Guideline 2.0 table, alongside and in collaboration with providers and plans. The two studies together, the first study that Bill mentioned, and this study, they show that guidelines are vital. They are vital to an overall approach to back and musculoskeletal injury prevention and treatment. A guideline inconsistent care augments the effects of treatment patterns, and aggressive but informed use of clinical practice guidelines can and should work. Ongoing assessment of guidelines and costs are needed, even with aggressive programs and excellent short-term experience. What this second study shows is that further cost savings and even better health outcomes will tend to be possible. Measurement and management of guidelines can improve health plan design and reduce costs. As Bill was suggesting earlier, we've actually looked at this in a number of different ways right now over the last 4 or 5 months, and we have consistently found that return on investment of 40 to 1, if not more, is possible. So now let me turn it over to Mike Ordell, the third panelist for our group, please. Thank you.
Thank you. And I'm just going to get this pulled up. Okay. And so I have been involved with low back pain care as a clinician and as a researcher, and also in the development of low back treatment guidelines, including the Agency for Healthcare Policy and Research back in 1994. I was a reviewer for the American College of Occupational and Environmental Medicine in the first edition of their Occupational Medicine Practice Guidelines, and also have been a editorial advisory board member of ODG, Treatment and Workers' Compensation Guidelines. What I'm going to talk about a little bit is the guidelines, the patient outcome aspects, the cost aspects, and also some of the ways that employers should be looking at these guidelines. One of the concerns that has been expressed in terms of low back pain is care patterns that should be improving, and yet they're not improving. So here was a study that was conducted by researchers in Boston. What they looked at was outpatient neck and back visits. They used a National Ambulatory Medical Care Survey and also a National Hospital Ambulatory Medical Care Survey over a 10-year period. Primarily what they looked at was what we would call low back strain, sprain, and excluded red flags. What I mean by red flags are other significant conditions. So we're excluding cancer, we're excluding fracture, we're excluding acute instability, a significant neurologic deficit. This is, again, simple axial back pain. And the pattern over time was the following, that the use of things like anti-inflammatory agents and acetaminophen, generally guidelines supported as effective and more beneficial than harmful, and yet over time the use of these agents goes down from 37% of episodes to 25%. In this period of time, what the researchers found was that opioid use increases from about 19% to 29% of cases, and we'll talk about that a little further. Physical therapy, one of the most effective things that we have to treat low back pain, utilized in 20% of visits. Imaging rose from 7% to approximately 11%. And in addition, specialty referrals went up from about 7% to 14% of visits. Again, the implications being that some of the care patterns that are guideline supported are decreased in utilization over this time period, and some of the care patterns that do not have guideline support become more prevalent. So along comes this study, and I think the significant issues with this study, looking at cost outcomes, there are some parallels in terms of the clinical outcomes. The finding that was different was that early referral to physical therapy and chiropractic care within the first 2 weeks decreased cost. However, they did confirm that early use of MRI for simple low back pain increased cost. There was a confirmation that the use of opioids before and after 12 weeks increased cost. And one of the more recent things that researchers have started to identify is the significant implication of the use of benzodiazepines, that's things like Valium, where use before and after 4 weeks increased cost. There are some further things that we've talked about in terms of analyzing how do synergistic effects play into this. So if you use an MRI early on, if you use opioids in addition, is there a synergistic effect? I think there are some implications in terms of the recommendations that guidelines make. And very importantly, that this information can't just sit out there by itself, but the findings of a study like this need to be thought of in terms of how they become integrated into guidelines in the future, and also patient evidence-based and shared decision-making approaches, especially in the group health setting where down the road insureds are going to have to be making decisions based upon their preferences, what the research shows, and also because of the considerations that they will have in terms of how much they pay for care as well, and you as an employer pay for care. So let's just talk a little bit about the guideline implications. So if we look at guidelines in general, as I said, anti-inflammatory agents found to be effective for acute low back pain and musculoskeletal conditions. Muscle relaxants, although they are commonly utilized, really should be used for short-term and primarily at night, and the reason is limited efficacy and the potential complication of sedation. Benzodiazepines, in terms of guidelines, generally have not been addressed in acute guidelines. They've been more commonly looked at in terms of chronic pain guidelines. The recommendation from guidelines being that use should only be short-term, 2 to 4 weeks max if used at all. Opioids we're going to talk about. An opioid in terms of low back pain, if used, should only be for severe pain where first-level agents are ineffective, primarily should be utilized at night, and really should be limited to approximately 2 to 3 weeks of treatment. And of interest, a number of different analyses have looked at the literature and felt that actually there's no clear evidence that the use of opioids is more effective than other agents that are much safer, like acetaminophen or anti-inflammatory agents. And what is the concern about opioids? And the concern is that over time we have seen greater and greater numbers of fatal and non-fatal overdoses from opioids. Most recently in 2012, CDC data, greater than 16,000 fatal overdoses from prescribed opioids. That is a staggering statistic. There are many regions of the country where the number of individuals who die from prescribed opioids has exceeded the deaths from unintentional firearms and the deaths that occur from motor vehicle accidents. One of the problems that we have seen over time is increasing doses of opioids for the treatment of musculoskeletal conditions. And at one point, there was a thought that, patients get used to the side effects of opioids, and there's no upper limit of the maximal dose that one could use, and don't worry about that. And that has clearly been shown to be incorrect, because the higher the dose of opioid therapy, the higher the risk of somebody dying from the opioids. There are other studies that are out there that have looked at the impact of opioids on disability, with as much as twice the rate of being disabled for individuals who have been prescribed opioids. And there are several other concerns in terms of chronic opioid prescription. Misuse of medications, illicit use, can be as much as 41%. And yet, these agents are not that effective. A study that was conducted out in Washington looked at individuals with low back pain and found that only 27% of long-term opioid users had significant pain reduction, and less than 16% had significant functional improvement. Other aspects to consider, and that is physical therapy, exercise, and manipulation for acute low back pain. In general, the literature is very compelling that exercise is beneficial. Historically, the literature looked at the use of physical therapy for acute low back pain only in individuals who had fear avoidance, and that is, I'm afraid of moving, I'm afraid of my pain, and therefore I'm not going to move. Otherwise, historically, guidelines said that one, as Harris said, should wait for a couple of weeks to see if one gets better. And yet this study clearly demonstrated that early referrals were associated with reductions of cost and reductions of the indirect costs as well. So that is an area where we need to look at the existing body of research. And I believe that the reason why there's the disjoint between the findings of this study and the findings of historic literature is based upon the way that randomized controlled trials are set up. Just to quickly talk about manipulation, literature on manipulation, there are ways that one can identify individuals more likely to respond, and that is what's called this positive clinical prediction rule. And that is, an individual who has acute low back pain without leg pain, no fear avoidance, much more likely to respond to manipulation. While manipulation is a passive intervention, if you combine it with therapeutic exercise, it becomes much more effective. I'm going to talk a little bit about the use of MRI for low back pain. Now, guidelines clearly demonstrate if there is clinical suspicion of a serious condition like cancer, like infection, like a fracture, like a very significant disc herniation with neurologic deficit, that one should conduct early imaging with MR scans. Otherwise, historic literature tells us that one should wait, because most individuals who have low back pain are going to get better in approximately 6 weeks, and that includes approximately 90% of individuals who have disc herniations are going to have symptomatic improvement without either injections or surgery. What happens if we go and conduct MRI scans for patients with back pain, again, without the red flags? So again, we're not talking about suspicion of cancer. We're not talking about patients with suspicion of significant disc herniations. Well, there's very interesting literature that's out there. One study looked at subjects who were referred for x-rays, and they either conducted an MRI or an x-ray. And what did they find? They found that by doing an MRI, there's a change in treatment pattern. There are more consults that are generated. There are more surgeries as a result. And part of the reason for that is the over-interpretation of an MRI. And the issue being that too often we see an MRI that has age-related changes, disc bulges, disc degeneration. Sounds scary, but we commonly see these things as a result of us aging. That study observed that MRI did not improve the 12-month clinical improvement in terms of symptoms, function, or satisfaction. There are other studies. Liberty Mutual did a study, Webster, published in JOEM, looked at early MRI for simple low back pain, again finding greater medical utilization, surgery, and disability as a result. Similarly, a study conducted out in Washington Department of Labor and Industries, twice the rate of low back disability, simply because an MRI was done that was unsupported, and there's a reaction both from the clinician standpoint and a patient perception standpoint that drives care. Of interest, a study conducted by ASH looked at subjects with low back pain And in one group, there was an early MRI conducted. The results went to the provider and the patient and the subject. And in the other group, there was an early MRI, and yet the results were not distributed to the subject and the provider. And what the researchers found, that the very act of doing an early MRI for the subject who knew what it said, that individual had a lower sense of well-being. Their general perception of their health, knowing that they had a age-related disc bulge or an age-related degenerative disc disease, made them feel less healthy. So what do we do about these things? There is emerging information that's out there in the Internet that it can be very useful for insureds. There is, unfortunately, a lot of information that's out there that is really not very good. And so one of the things that I'm hoping over time is that we focus individuals on the better websites. And I put up two here. One is Consumer Reports, very recently, where there is a publication, Is There a Right Way to Treat Back Pain? And what it does is it promotes a lot of these evidence-based approaches, and it puts a caution on the overutilization of injections and surgery and imaging. Choosing Wisely has a very nice campaign that's out there. It is a collaboration of the ABIM Foundation with multiple physician specialty societies. And one of their nice publications is on the appropriate role of imaging tests for low back pain and to encourage individuals to not have an MRI when they don't necessarily need it. With that said, I'm going to stop here.